I'm Dr. Tracy Stecker, and welcome to the Choosing Help podcast. Choosing Help presents conversations about courage, connection, and the transformative power of asking for support. Through candid discussions, expert insights, and real-world stories, this podcast breaks down stigma and opens doors to understanding. Join our community committed to compassion and courage, because when we choose help, we choose life. This is Dr. Tracy Stecker, and I'm joined today by Dr. Charles Hoge, and we are going to talk about military and veteran help seeking. Dr. Hoge is a retired Army colonel. He's a psychiatrist, and he's the author of Once a Warrior, Always a Warrior. Hug. Um, he directed the mental health research program during the wars in Iraq and Afghanistan, and he works with service members, veterans, and their families in the Washington, D.C. area. Dr. Hogue, you and I have talked a lot. You know that I've worked a lot with veterans in my career. There's a couple things that I've noticed working with veterans: incredibly competent, always on time, if not
Yeah,
early,
yeah,
very
usually early.
responsible, great work ethic. Do you mind characterizing military and veteran populations for a minute, telling us a little bit about what they're like and then what you see as their mental health concerns?
Yeah, sure. I think sometimes people have, when they think about veteran populations, they think about, people who go to war and come back traumatized and maybe need mental health. But and there's a lot of stereotypes that people have of the military, like that,
Absolutely.
that the services recruit from more disadvantaged populations or folks who, join the military because don't have other options in life. And all of those are misunderstandings of the military. In fact, the military selects a top percentage of the population in terms of, education and skill level. They're very selective in who joins the military. And then they go through, rigorous occupational training in the military and and then when they transition out of the military after their service, they may have, there's a variety of military roles they may have served in. When they come into the civilian society and transition, they're often bringing really substantial skills with them into the civilian workplace or into,
Hmm.
university settings and that kind of thing. And so sort of the misperception that they're all jacked up is kind of, really a misperception. I think it's important to kind of, acknowledge that there are stereotypes up front and to counter those stereotypes, because I think
Hmm.
that's really important. And they bring just tremendous skills to the workplace. That said, they also go, like, it's an occupation, especially for instance, infantry occupations or occupations that involve war fighting. These are very dangerous jobs. And
Right.
so, service members go through experiences. They're kind of more aligned with maybe what our first responder, police force, and firefighters go through, but but oftentimes even much more intense in terms of the types of experiences that they may have in combat zones. And so, do they go through trauma? They certainly do.
Hmm.
Do they come home with the effects of that trauma? Are there psychological costs of the work that they do? Absolutely.
Hmm.
And it's a population, that's about 15% of active duty military are women, 85% are men. The average age is quite young. These are mostly young men. Young men don't typically think about going to get mental health care. There's a lot of stigma. There's a lot of bravado.
Hmm.
They sometimes worry that they'll be treated differently or viewed differently if they get mental health care. And so, they don't necessarily they often don't get the care that they need, after they've
Hmm.
had the experiences that they've had. And so, there's been a lot of efforts on the part of both DoD and VA over the years to try to counter that stigma, improve, reduce barriers to care, improve access, improve people's, willingness to come in and get the care that they need.
Yeah, I had talked to several veterans who served in wars who indicated that they knew exactly what they were getting into. They signed up, they were ready. They
Yeah.
were absolutely ready for what they would experience. What they didn't prepare for is how it would impact them once
Right.
they got home.
Right.
That it can take some people by surprise, even if they're aware of what they're getting into.
Yeah.
And so, on that note, what have you seen have been some of the beliefs about help seeking, getting mental health treatment? What kind of thoughts? My work has shown that there is a stigma against mental health treatment. There is the thought that they can handle it on their own. And another big one that comes up is if I go to treatment, it will impact my position either in the military or at my job.
Yeah.
Uh, Is that accurate?
Oh, absolutely. Yeah, absolutely accurate. I mean, stigma is mental health. The stigma of receiving mental health care is pervasive in society in general. But in the military, I think you have, maybe I wouldn't say that it's greater stigma than in the civilian population, but because the demographics are different,
Right.
young men tend not to seek care, whereas in civilian populations, it's more equal, men and women. Women are more willing to come in and get mental health care when they need it. They kind of have a better sense of when they need it, and they tend to be more willing to go in and get care, whereas men are oblivious to the fact that they have mental health problems sometimes, or even if they do have problems, they're so worried about the potential impact that they don't go in and get care. I think, when I started studying this. I was running a research program early in the wars in Iraq and Afghanistan. And one of the first studies that we did was to look at the impact in terms of the number of soldiers who were having combat related events that led to PTSD and depression.
Hmm.
But we also studied how many of those individuals needed care and weren't getting it. And we had questions on our surveys about stigma and barriers. And we were really focused on, questions like, the perceptions like my leaders would treat me differently, or I'd be treated differently by my peers, or it would damage my security clearance, or stuff, those sorts of items, that stigma items that a lot of service members had perceptions about. And perceptions lead to behavior, right?
Correct.
And we assumed that those were the reasons that people weren't coming in to get care. And to some extent, that's true. But what we learned later with further research was that one of the strongest predictors of not coming in to get care is just the feeling of self-reliance that
Hmm.
many young men have, and people in the military have, is the feeling I should be able to handle this on my own.
Hmm.
And there's also a lot of negative perceptions of mental health care out there. There's a lot of folks who even have attempted to get mental health care and have had bad experiences sometimes. Maybe they've
Hmm.
had difficulty getting into care, or they got or they felt like they were being dismissed when they tried to seek care, or they they got a provider who they felt was judgmental or didn't understand their situation. And so a lot of folks, one of the biggest problems actually is that when people from that community do come in to get care, many of them end up dropping out of mental
Hmm.
health care.
Hmm.
And I think that feeling of self-reliance and and the negative perceptions of mental health care really drives a lot of the behavior of the help-seeking behavior and decisions of whether to come get care or not.
And so talking about dropout, just getting individuals who might need help into treatment is one big obstacle
Yep,
because the majority do
that's
not
right.
come in. But then once they come in, we do have an issue with retention. They don't tend to stay in treatment. What are some of the causes of dropout that you've seen?
Well, I think that some of those are the same as the reasons that they don't come in to
They
begin
can
with.
do it on their
Yeah,
own.
and
Yeah.
there's a lot of reasons why people drop out. Sometimes they have other priorities in life,
Right.
work-related priorities or childcare or whatnot. They have difficulty getting the childcare that they need to go to their appointments, or their appointments aren't at convenient times, or they interfere with training schedules, or they don't want to be kind of singled out in the command as
Hmm.
needing mental health care. And so they avoid getting care, for a lot of reasons. But many times it's similar to reasons to come in. And actually, a lot of within the DoD, in the beginning when we first started studying this, the majority of folks who needed care, in fact, did not get care.
Right.
But then over the years that changed, and I think it's probably fair to say that the maybe the majority of people who need care are actually touching mental health now. And
Okay.
a lot has changed. When we started, the percent of individuals who endorsed getting mental health care who had significant mental health problems was only 20%.
Hmm.
And now it's probably around 70%, right?
Wow.
Or,
Okay.
but the problem is that even though they're touching care, they're coming in, they're seeing someone, maybe one or two sessions. Oftentimes it's only one session, and
Hmm.
then for whatever reason they drop out,
Hmm.
and oftentimes it's they maybe they perceive that it's not going to be helpful, or they again feel like they should be able to handle it on their own, or other life events intervene to make it difficult to get to appointments. So there's a lot of reasons.
Yeah, and one we should probably touch on is also because I've heard it quite a bit. If th there was any sort of traumatic experience, they don't
Hmm.
necessarily want to talk about it, and so
That's right.
there is that sense
Mhm.
of they're gonna ask me what happened. I don't want to talk about it, and as humans, we're designed to avoid discomfort.
That's
It's
right.
just wired in. I don't want to go there, so I'll figure out some sort of other way
That's right.
to be okay, but not talking about what happened there.
Yeah, that's exactly right.
Yeah. And so if somebody does decide to go to treatment and there's any sort of sense they're going to have to talk about a traumatic event,
Hmm.
they
Yep.
they might be gone.
Yeah, and oftentimes, that's the engagement piece. A lot of times when we start working with military and service, I think this is true in civilian populations as well. But when we
Right.
have veterans and service members coming in, and they know they're struggling with PTSD symptoms, and they know they need help. Maybe their spouses have been pushing them to get care, and they finally come in to get care, and you know we sit down for the first time, and they feel some sense of relief because they're finally there. And we go through a brief history. We don't go into details in the first. We do sort of a comprehensive initial assessment. We develop a treatment plan, and then we're at the point where we want to invite the client to come in and roll up their sleeves and actually do the trauma focused therapy that they need, right?
Right.
And then they're like, okay, I'm gung ho, I'm ready to do it, and so I'll go, okay, next Tuesday I'll see you at 9 o'clock in the morning, and we'll do our first treatment session. And then they don't show up,
Right.
and very often it's because of fear,
Hmm.
that it's going to be too hard, or it's going to feel.
Hmm.
They oftentimes, when you're holding on to traumatic experiences, it feels like Pandora's box, and
Hmm.
that as soon as I go in and sit down and start talking to the doc, the lid's going to come off. I'm not going to be able to handle it, or I'm not going to be able to stuff everything back in the box and go back to work at 10 o'clock at the end of that appointment, when
Hmm.
I have to be at work. And how's that going to feel? And so there's a lot of, it sometimes takes a little bit of time to kind of help people to feel comfortable, with getting the care they need.
And so I think that's something that we should do a better job of communicating is
Mhm.
that um, they don't have to talk about it the first session. They
Mhm.
don't have to talk about it at all. When you're working with somebody, you really do have some say so in your
That's
own
right.
treatment, and you're allowed to say, "I can do that, and I'm not ready for that part," or "Will you help me get ready for that part?" It's
Exactly.
collaborative, and so I think as providers, we could do a better job preparing people for treatment before they even get there.
Yes.
Is there
Yeah.
anything that you do when you're working with somebody to help get them ready for treatment so that they'll follow through?
Yeah. I mean, I think I prioritize the engagement up
Hmm.
front, as a
Okay.
number one priority is to help them to feel comfortable to come back.
Hmm.
So, some of the things that can help with that are just simply asking, what are some of the barriers to care? What are some of the things that you're worried about? Or what are some of the things that might interfere with your ability or willingness to come back next week?
Yeah.
So just having that kind of conversation and not jumping right into some of the harder work. And the other thing is that there are a lot of options, as you pointed out. And, trauma, like for PTSD, trauma focused therapy, which is a scary term just to begin with, right? A lot of people are like, they don't
I
want
don't
to
want
touch that.
that.
Yeah, I don't want to touch that with a 10-foot pole. But there are a lot of therapeutic modalities that don't involve a focus on telling the story,
Hmm.
that don't even involve a trauma focus at all. Things like
Hmm.
personal therapy or certain types of supportive therapy, or even there's a really wonderful study of a form of meditation called transcendental meditation that was on par with one of the top therapies. It was found to be on par with one of the top therapies that's offered in the VA and DoD. And so
Right.
there's a lot of options out there. And so, and the other thing I like to tell, people, both clients as well as, or patients as well as, clinicians, is that that if a patient comes in and sits down with a clinician and they don't click,
Hmm.
that's okay, right?
Hmm.
And the most important thing is to encourage them not to get discouraged and not to leave therapy and just say, well, mental health's not for me, right?
Right.
To
Right.
and it takes a lot of effort sometimes to find the right match.
Correct.
And I think that a lot of healthcare systems don't really attend to that need very
Hmm.
well. They
Hmm.
kind of have the perception like one clinician is as good as another clinician, and you
Hmm.
get what you get, and it's if you come in and say that you want to change practitioners because you don't like the first person, people get all offended and stuck up
Yeah.
about it. But it should be a fairly natural thing. If you don't click with your therapist, don't run away from therapy. Ask to see somebody else. Try to find some, continue to stay engaged in care and try to find somebody who you can work with, who you feel comfortable working with.
Yeah, I think options are key. And so if we can even just stay there for another second. In my work, that was the number one barrier presented to why I'm not coming to treatment.
Mhm.
And usually it went something like, if I go to treatment, somebody will give me a medicine,
Mhm.
or if I
Right.
go to treatment, they'll force me to go to AA.
Mhm.
And it's very freeing to know that you can choose which option you believe will work best for you. Going to treatment does not mean you're going to get a medication,
That's right.
and going to treatment does not mean you're going to be forced to go to AA. That choice lives within you for the most part. And so knowing you have options, I think can be a really important first step that I'm not sure we're good at letting people know.
Yeah, I agree. And there another thing is that when we start talking about PTSD treatment in particular,
Hmm.
PTSD treatment, there are several, evidence-based types of treatment that are recommended by the VA and DoD, strongly recommended by the VA and DoD. But one size doesn't fit all, and a lot
Right,
of time, and the dropout rates from trauma-focused therapy, the most commonly used evidence-based approaches like prolonged exposure therapy or cognitive processing therapy or EMDR, the dropout rates from those treatments are very high. In some
right.
studies, they've been upwards of 50% of people who start those treatments drop out. And so I think that it's very important for clinicians to be able to be flexible in therapy and to, again, prioritize the engagement piece over the let's get through each session in exactly the explicit way that the manual asks us to do that. So
Right.
we want to try to adhere to the evidence and the manualized approaches to treatment, but we also have to meet the patients where they are
Yeah.
in a way that helps them to feel comfortable coming back. So if we start one type of treatment and the patient, it's not working for the patient, or the patient is feeling too uncomfortable with that type of treatment, then
Right.
being able to adjust fire and say, well, there's other approaches that we can do. There's written exposure therapy. There's, certain
Yeah.
types of therapy that don't even involve a trauma focus at all. And having that flexibility of being able to shift gears with the patient, and look at what the broader range of options are can be really helpful in helping people to stay engaged in care.
And so if there's an individual that's listening and they're thinking, whew, I probably would benefit from working with somebody about a traumatic experience I've had. But I know I'm not ready, and I know it's going to come too fast for me. We're here to tell you that it's okay to say, I need to slow down. I
Right.
need to go a little slower. Can we take this at a slower pace? I need more work to be able to be ready.
Yeah.
That is okay. We're here to tell you
That's it.
that is okay to request.
Right. Yeah. Yeah. I mean, sometimes the thing that people most need in the beginning is just some simple tools for how to better regulate the reactivity that they're experiencing.
Right,
Their heart rate's jumping up, they're feeling panicky, they're feeling a lot of anxiety, they're getting triggered easily. And if they just have some tools that allow them to better regulate themselves, then oftentimes that can then, later on they can do some of the more, specific work on processing, the
right.
experiences that they've had and integrating those experiences into their life. But just having some simple tools to start with can often be really, really, really helpful.
Yeah, and I'm going to say that part again too.
Yeah.
We can help you regulate your heartbeat. So when your heartbeat starts pounding and you feel like you can't catch your breath and your thoughts start racing, we have we can teach you how to take a moment and take that heart rate and get it back down, those thoughts to stop swirling so that you're able to take a step forward. You don't have to continue to feel like those feelings are going to be overwhelming, or you even have to avoid them because we know how to control them
Right.
better, a little bit better.
Yeah, exactly. I think a lot
Okay.
of people also think that, like their mental health problems are in their mind. But
Yeah,
the experience of mental health problems, the experience of, trauma-related symptoms and many other conditions, the experience is a whole body experience, right?
right,
When a person experiences anxiety, they're not just experiencing it up here, they're experiencing
right,
it with their whole body.
right.
So having that sort of more body focus to the approach to care can be very helpful.
Yeah, even so, even just a podcast like this, for some people, it would be terrifying. Their heart would be racing. Um, and so their thoughts
Hopefully
might
not
be
too many people, but
their thoughts might be something like, I can't do this. I can't survive it. It feels like I'm going to die with my heart pounding like that.
right.
And other people, their thoughts are, Look at this. My heart's pounding. I'm
Mhm.
so excited." And
Right.
so it's another thing to tie the mind, which is involved, and the body together, get them more aligned, get maybe a more truthful experience about what's happening for you,
Right. Yeah.
including about very traumatic, horrific events.
Yeah.
So also family members, because I know you've
Oh,
worked
yeah.
with family members a lot. Is there anything family members can do to help a loved one consider seeking help?
A lot of things. I mean, a lot of times service members and veterans really will not come into care until they're really nudged by their family members.
Okay.
The tricky thing, of course, is that if family members, push too hard or too demanding in that regard, then that can, build barriers or resistance and so forth. So it's delicate, it's delicate it's hard for families sometimes to navigate that,
Hmm.
especially when a veteran is, hell bent on not coming into care,
Hmm.
and the family knows they need care and they think that the world is, that their life is perfectly fine and they don't have any problems. It can be really, really challenging. And
Hmm.
just so for one, so the most important thing I think for family members is first and foremost to take care of themselves,
Okay.
right? Because there's a lot of codependency that happens. Sometimes service members and veterans, of course, mental health in general, there's a lot of coexistence of other conditions. There's a lot of, quote unquote, self medication with alcohol and substances
Hmm.
can intervene with, family dynamics and life in general and so forth in a number of ways. And so, you know, um, it's important for family members to recognize, like, if a veteran is drinking in order to get to sleep, or drinking to cope with the demons that they brought back from the combat zone, and they're not willing to get care,
Mm-hmm.
ultimately it's the veteran's responsibility. And the family member can try to open the doors, try to help them get an appointment, try to help and, encourage them to come in and get care. But ultimately, they, that it still is an individual responsibility. And the family member, if they get too caught up trying to, focus on the veteran, they end up putting their own life on hold. You know what I mean?
Right.
and
Yeah.
and it can be, they're traumatized also, secondarily, by what they're witnessing, and how their loved one is acting around them. And
Mm-hmm.
so they have their own trauma, they have their own things to deal with.
Mm-hmm.
So it's important for family members to get their own care,
Mm-hmm.
and to take care of themselves. And then, just like, on an airplane, you put your own mask on before you help your child, right? It's sort of, that kind of a perspective. So take
Mm-hmm.
care of yourself, but then, to the degree that you can continue to encourage your loved one to get care. That's, that is really helpful to a lot of veterans.
I feel like this time flew together,
Hmm.
and we're going to have to bring you back to talk some more. Thank you again for joining us on Choosing Help.
Sure.
I just want to say to anybody who is considering seeking help, or who has a loved one who is considering seeking help, you can consult our website, choosinghelp.com. There's a resources tab, or you can contact us. And we're going to say goodbye, and thank you so much for joining us.
Great. All right. Thank you very much, Tracy, for inviting me to this.
Thank
It's been
you.
great. Yeah, really enjoy it.